Neither the El Paso Medical Society, its members, nor PBS El Paso shall be responsible for the views, opinions, or facts expressed by the panelists on this television program. Please consult your doctor.
You may have a cough right now, you may have the sniffles right now, you may have a sore throat, you might even have a headache, and you just don't know what you have, and you're thinking, uh-oh, what's going on? Again, this is the time of COVID. It's not quite gone yet. I know all of us think and wish that it is, but we all just kind of think, oh, it must be allergies. It might be a cold, and this is spring. So during the next hours, we have a couple of experts that are going to tell us what symptoms we are feeling and what it might be, and also which tests we need to take, and then kind of take it from there. As you know, this is a live program. The telephone number to call is 881-0013. You will also get to watch this show later on both PBS El Paso and also the El Paso County Medical Society website. But again, ask your questions because we're here to answer them. That's our job. We are live. 881-0013. This evening's program is underwritten by the American Heart Association, so we can bring all this information to you. We also want to thank Texas Tech Paulo Foster School of Medicine for providing our medical student here this evening. And we have a third year with us. Melissa Huddleston is here, and she is a third-year medical student, and she has joined us quite a few times in the past. She originally is from Georgia, and she will find out next week where her match is to do her residency, so it's really exciting to have her here. I also want to say thank you to the El Paso County Medical Society, who has been bringing the show to you now for 25 years. This is our 25th anniversary. I'm Catherine Berg, and you're watching the El Paso Physician. But I've known them for 20 years. We've been doing the show for 20 years. You know, he talks about farts, and he talks about diarrhea, and he talks about all kinds of things that nobody wants to talk about. And that's what's great about the show, because you get to hear those things on the show and go, I'm not the only one. It's great. It's the El Paso Physician. Thanks again for joining us. It is allergy season, so I think that all of us have a Kleenex, or excuse me, a tissue, can't say brand names on the air, stuffed up our sleeve or in our pockets. We've got stuff going on. With us this evening, we have an allergist, also an immunologist. That's a word I always feel like throwing an extra N in there. But Dr. Adrian Casillas is with us this evening, and that is his specialty, and we're going to talk a lot about allergies. And El Paso is specific when it comes to allergies. A lot of deserts are, and we're gonna go into that. And then Dr. Diana Escobedo, who's in family medicine, you're off in the front line of somebody just, I got stuff going on, help me out. Where am I gonna be going with this? So on that note, I'm going to start with Dr. Casillas and ask you, as an allergist here in El Paso, I know that you were doing a lot of work in LA, you said. You were with UCLA for a lot of years, and it's different here than it is there. And with many disciplines, it's not. But because we're talking about air, and we're talking about quality of air and allergies, what is it that you do all day, every day? And it sounds like such an easy question. We can go on for 4 or 5 hours. But to explain to the audience at home what your specialty is in El Paso, how would you explain what it is that you do?
So, as a board-certified allergist, immunologist, my job is to really combat chronic inflammation that is caused by allergic mechanisms. Okay, so that means diseases like, as simple as hay fever, allergic rhinitis, as a simple variant of that, right? And then very severe respiratory disease like asthma, where people really struggle to breathe because of, and these are both inflammatory diseases. They're chronic inflammatory diseases. There are many other forms of allergy, obviously. There's allergies to medications, there's allergies to foods, right? There's even allergies to other people.
I've heard that, but I'm not sure. I think it's an excuse a lot of people use, but.
But the reality is that, so this is, it's a form of inflammation that's triggered by an allergic mechanism, a specific type of antibody that some people make when they're unlucky and other people don't. It does require exposure to that substance, whether it's a drug, a food, pollen, granule, a dust mite particle, whatever, in order to mount that allergic response. There are certain things that may promote that allergic response to be worse in some people or not. And then there's ways to lessen those effects. if we talk about treatments and, if someone's interested, we can certainly talk about that.
Yeah, and what I'm going to get into in a little while, because there's just that curiosity of what makes one person allergic to something and not the other. But we've got a whole hour, which sometimes seems like a lot, but it's not. But Dr. Escobedo, let's talk about you for a moment. And I know I ask the doctors, what do you do all day, every day? It's like the catchphrase, right? They say, is that what you're going to ask me? But as a family doctor, and I love that you were born in Juarez, you said, grew up in El Paso, born here, and did school in Juarez, studied in Las Cruces, et cetera, et cetera. So thank you both for coming back. But talk a little bit about your practice, what you do all day, every day. Who in general do you see during the day?
I'm a community doctor, and I'm based in Horizon City, so it's a pretty, developing part of El Paso. We have a lot of dust, so I see a lot of allergic conditions. But what I do every day is taking care of anyone that comes through my door, be it babies, newborns, to older people.
So it's anybody and everyone. So you're going to be the question that is the frontline person. Okay, so somebody comes in, what's my problem? You're the first one that sees them usually, that way. So we talked a little bit about this. So we were just on live Instagram, and we were talking a little bit about why our bodies make mucus. It's one of those things that with all the conditions we're talking about, when you have a cold, when you have allergies, COVID, the flu, just in general, our bodies are put into some kind of a gear to make snot, to make phlegm, to make, anything that's going on. Why is it physiologically that our body is doing that? What's that reaction creating?
So basically, it's a reaction, exactly. It's a reaction against something. So the body's mechanism to clear things out of the respiratory tract or the GI tract or any mucosal surface is to create something that will glide it out of the body, if you will. Okay, so
that's a good way of describing it. Gliding it out of the body.
Right.
It's exactly. If you picture it, that's exactly what's happening.
It's a simple way of thinking about it. It's our body's way of saying, I got to get this stuff out of here, and in order to do that, I've got to create a river, and let it go out somehow. Okay, and it doesn't matter as long as it leaves the body. Okay, and sometimes it happens in unfortunate ways, and other times, a simple tissue will take care of that.
Exactly.
But you understand. So that's basically what mucus is. It's a combination of proteins and sugars that capture certain things and carry them out. And that's basically what it is. It's a cleaning mechanism for the body in a simple way of thinking of it.
I need to get you out of me and out of me now. A question here. What I'm gonna do is, I know it is allergy season and it's springtime, but the first thing I want to do, we've got 6 really cool slides, and I want to throw these up because I think questions are going to then be derived from the slides later on. So if we can put up slide number 1, because the topic this evening is if we have allergies, if we have a cold, if we have a flu. We're going to talk about flu shots in a few moments too. And then there's, again, still COVID out there. And so if we can throw up slide 1 that has the fever, and it's going to kind of give us a snapshot of what it is that we think we may have if we're not feeling well. And this goes into, Dr. Escobedo, your questions. Like somebody's coming to you, and just by looking at them clinically, sometimes you can't diagnose, you have to go into the testing phase. But knowing the differences between allergies, flu, and COVID, we've got here, do you have a fever? And why is that such an important thing? If you have a fever, other than or in combination with the mucus, what is that telling people?
Yeah, it's telling us that there's possibly an infection, right? We hear fever, and we automatically, as doctors, think, an infection of some type, right?
Which makes it more serious in your head? Would that automatically go to this is more serious, or more about diagnosis?
More about diagnosis, right? Now that we have COVID and flu and all of those, we need to make sure that we're not dealing with those 2 conditions first. But some other conditions, severe allergies can sometimes give you, people feel that they have a fever, but they don't check it, right? Or other autoimmune conditions can give you fever as well. It's not always an infection, but most of the time it is.
Okay. And so we have here up on the screen, if you do have a fever, chances are it's COVID or the flu. If you do not have a fever, but still have the itchy eyes and mucus and everything, you may have allergies or you may have a cold. And if we can go to the second slide, which is type of viral tests. And like I said, I want to not get these out of the way, but I want to look at these so that as questions are coming in, we know what we're talking about. So the test we say, and Dr. Escobedo, I'm going to go with you first because again, you're that first line, right? So you now order a flu test, you now order a COVID test, or both. How is it that you order them? Do you do it there in the clinic? Do you do it in your office? And how long does it take to get the results back? I know COVID takes a while, but.
No, well, there's different types
true.
of testing,
That's true.
right? Now we have the convenience of getting an antigen test in the clinic, and they actually tell you COVID and flu at the same time.
Right,
So
okay.
that's pretty awesome because you can get that test done and be done with it in 15 minutes, right? But sometimes, sometimes the person that's taking your sample and it's a nasal swab, it's not as good as taking samples, or you're too early to get diagnosed, and
Right.
so it could be negative, right?
Exactly.
And you can still
I'm
have
so glad you said that. And I
COVID
know
and
I'm
flu.
interrupting you. And the reason I do that every now and again is I'll hear something and I'll forget it later. But when you said it could be too early, usually, if I read this right, for exposure of COVID to actually show up in a test, it's about a 5-day process.
Now
Is that
that we're
correct?
all of us are vaccinated, a 5-day is recommended, right?
Okay,
Obviously,
okay.
if you have symptoms before you can test, and you might get a positive test, but the most reliable is at 5 to 7 days.
Okay, if you know you've been exposed.
And if you have symptoms.
And if you
right?
have symptoms.
Some
Well,
kind of
that's a good
symptoms,
point. Okay.
because now that we're vaccinated, we get milder symptoms, right? Like sore throat or nasal congestion, that before we would get the cough and the really
Right.
feeling really sick. Now it's mild.
Right.
So even if you have a mild symptom, you can test before, and you might get a positive test, but recommended is 5 because we have the vaccine.
Okay, makes perfect sense. And I know we had that on the screen a little bit earlier, but if you are negative, life is good. You're just gonna have to wait it out, so to speak. But if you are positive, I just wanna, again, our job here is to kind of educate the audience, but isolate for at least 5 days. I know that used to be 10 days, and now it's down to 5 days. And then seek some kind of a follow-up test to make sure that you're clear later on. And that's to protect others, because even if you're talking about most people are vaccinated now, so your symptoms may be a lot less severe, but then there are those that may not have been boosted or for whatever reason are getting it a little bit worse. And then monitor your symptoms. I think we've all heard this over and over again. And when we get a chance, we'd like to throw up the slide about the COVID signs and symptoms. But Dr. Casillas, I'd like to kind of jump ahead. I know we've got the flu chart here, but we were talking earlier before the show about when you're tested positive for flu, there's flu A and flu B, which I never think about. I heard about it 10 years ago, 15 years ago, but I never think about it. So because there's flu shots, and we do want to stress that flu shots are still a thing. It is spring, but it's not too late to get a flu shot. So I'd love you to talk a little bit about that, and then talk about flu string A and flu string B.
So basically, I'll address the second part now, and that
Okay.
is, they're just different strains of influenza. Okay, every year influenza recombines. Okay, it's a little more complicated than just simple mutations, because they can recombine from different sources, different animal sources. Okay, and this is tracked throughout. The World Health Organization tracks all of this to make sure that by the time the flu hits a certain area, we kind of can predict what is the strain that predominated. And we don't know that. Sometimes it's, hey, there is no influenza B this year, it's all influenza A. That's possible.
Yeah,
it's not always
exactly.
that you have one and the other. It just depends on what happened that year, conditions and so forth. And then one thing you did say, as part of the first inquiry was that, we are seeing some less now because we've been taking precautions. And that's been a really good thing.
Agreed.
It's been a good thing that people now are, actually, we're thinking, well, maybe we should wash our hands, and for 20 seconds,
Don't touch your face, wash your hands. It's still a thing.
And that's a good thing. Maybe I
Right.
should wear a mask. Maybe I shouldn't go to that place,
Right.
with a bunch of yelling, screaming people. So these are all things that I think have really mitigated a lot of the flu in general, and we have seen a lot less. Who it's bad for is the people that are predicting what strains are coming out, because hey, there's no cases of flu to study.
Exactly.
So that's
Right.
become a difficulty. But still, people don't realize that a few years ago, I mean, almost 100,000 people died of the flu.
Yeah.
People, tens of thousands of people die of the flu.
So this is a beautiful transition in strain A, strain B, and then we're talking about COVID and variants. And I think about this too, as you're saying through the World Health Organization, that there are different parts of the world so that by the time it gets to another part of the world, the vaccinations are more specific to what strains are out there. And I'd love for you to marry that idea to the idea of COVID, the Delta variant, the Omicron variant, a variant that may still come about, because that is similar in the way the dance is performed, correct? So if you can kind of explain that, because that is the big question. It's like, oh, there's Delta, and then there's Omicron. Well, how many variants are there, and how bad is it going to be? It's always mutating.
So that's correct. There's always changes, and these are specific types of viruses that are just easier for it's just easier for them to mutate. Okay, and the RNA viruses are classic examples of this, and both COVID and influenza, are RNA type viruses.
Right.
So that's just the genetic material that they're made out of. And the bottom line is that if you can guess what's going to happen, then you'll be golden. You can
Right,
design your own
exactly.
vaccine, but that life isn't that good, right? So with the flu is probably one of our worst vaccines because of the fact that we don't always guess right. The people that are in charge of that, they do their best job to do it, but sometimes things change after they've reported what they think is going to be the predominant strain,
Exactly,
and you're
right.
like, uh-oh.
Yeah.
And so we may not even hit
It's
a 50%.
not a perfect science.
Correct,
Right.
it's not.
Yeah.
So people have to understand that. And not everyone responds just as well, and so on and so forth. And with COVID, what we've seen is that, it's easy for that virus to mutate as well. And we certainly have seen it. I think we paid attention over the last 2 years, what's been going on with COVID, and what does that mean that it's a major...
I think it's educated all of us. Those of us that weren't paying attention before,
That's
we're now
right.
paying attention.
That's exactly right. And for whatever benefit that has resulted in, I think that it's important to understand that vaccines are developed against a certain viral strain, if you will, and that is because it exists at that time. But that can change.
Right,
Okay, it can change.
right.
Just like a bad card game. You may be dealt with
It's like
something.
a bad card game.
Something
The
awful,
Joker.
right? That was used to be a good hand, and it changed. And that can happen.
I love it, right.
So I think it's important that because of these variations, it can change the molecular structure enough that now the antibodies you made to the original vaccination version may no longer really apply, or
Exactly.
may not apply to the same effectiveness.
Right.
People sometimes say, well, wait a minute, I've been vaccinated.
Exactly.
But wait, you were vaccinated to, brand A, if you will, and now it's not brand A anymore.
Right, which is and I'm so happy you're bringing this up. And Dr. Escobedo, I'd like to go to you now, because I would assume and imagine, because we hear it everywhere, it's like, well, I have been vaccinated. Well, I got my first one, so I should be okay. The questions that are coming to you and how you explain this to, again, being on the front line. Do I still need to get vaccinated? I haven't been vaccinated yet, but COVID's over. The antibodies, the idea that, yeah, we're going to have to get the COVID vaccine again next year and the year after, and it's going to be a little bit different every year. How do you explain to people that come into your clinic the very thing that Dr. Casillas is explaining, but again, just truly with the vaccine? When I say the vaccine, I'm talking about the COVID vaccine, because I'd imagine you're still getting questions on that.
Yes, definitely. And I always answer these questions because I want them to get vaccinated, right? Because I want them to get protected in some way, because it's not over yet.
Right.
So if you have one vaccine, you need your second vaccine at 3 or 4 weeks. And every time you get a vaccine, your symptoms are going to be milder, right?
And even if it's not an exact science, you're better to get it than not. And that's the part I'd like for you to verbalize somehow, because it isn't. And I love the reality of the way that you're speaking, Dr. Casillas, because it's not exact, it's not perfect, but we do the best that we can with what we've got at any given time. And that's so important.
Yes, and I've told, how I explain it is you might get COVID every 2 months if you don't get a vaccine, right?
Right.
Because it can mutate, like we saw Omicron, and then like 2 months later we saw another variant right after. So,
Right.
and you get reinfected every time, even if, when you don't have a vaccine. When you have a vaccine, I've seen patients that get one vaccine, and yes, they get the symptoms, but they're milder as if they, compared to the person that didn't get the vaccine, right?
Right.
And when they have the booster, they might be in close contact with someone and they don't even have a positive test ever.
Right. Getting some questions here from the audience. So I'm going to Dr. Casillas. What I'd like to do really quick before I start asking the questions here from the audience, when we were talking about allergies earlier, we were talking about specifically El Paso compared to other places in the world, fine, but in America. And you spent some time in LA, and I think sometimes that's similar to our climate a little bit. But what is it about El Paso that people think, wow, I travel everywhere and I come back home to El Paso, or those that have left El Paso leave and then come back and their allergies come back up? What is it that makes us allergic to stuff?
So El Paso is a very unique environment, but let me back up a little bit. The way you become allergic to anything is you get exposed to it. You get exposed to it for a period of time. So you're not born with allergies. I get this question all the time. Well, my dad had penicillin allergy. Does that mean I'm going to have penicillin? No, but you have the potential to be allergic to something. You have to be exposed to it.
Gotcha.
So exposure is required.
Okay.
So that's the first step, okay? Your immune system has to see it over
And not
time.
like it. Okay.
Well, it likes it, but in the wrong way, like a bad relationship.
Likes it too much.
Yeah.
I am digging this show. Okay, yes.
Okay.
Right.
So what are the conditions that make allergies worse in general?
Right.
Okay. Well, number one, having more exposure to that which you are allergic to. So if you think about it, pollen and stuff's supposed to, settle on the ground, kind of stay there, right?
Right.
But in El Paso, what's our experience? You
We've
can't
got
even see the
wind.
mountain right now
Right.
because the air is blowing everything every which way. So we don't get mild breezes here. We get this horrendous wind that comes, it gains speed as it comes down the mountain and just blows all over the place, right? So
Right.
we have resuspension of pollens and other things that we're capable of being allergic to just by virtue of the fact that we have high wind. Okay, that's one thing. Second of all, we have factors that augment allergic disease at a certain time of year. And it took me a while to realize that. When I came back to El Paso about, 6-7 years ago, after having been in Los Angeles and Houston, I began to hear that all the time, and I don't want to belabor the point, but the bottom line was, it's like, what is it about El Paso? And it is, yes, we have all that high wind, so everything's in the air blowing around. And also, when it gets cold, the poor people, I think, in Juarez, start burning strange things. And
Right.
those hydrocarbons mix with those allergens. And that combination augments allergic disease almost 100 times of what it would be otherwise.
No kid, hydrocarbons. So
Hydrocarbons, yeah, I used to do
burning
research on that, and I know that for a fact. So, like diesel particulates to something you're
Right.
allergic to boosts what you would normally respond with by 100 times.
and this is where your body says, I don't
And
like
this
it.
is that's why our threshold for having symptoms and bad symptoms
Yeah.
is much worse in places like El Paso. And it's a very unique where else that has that combination. I mean, we have a lot of other stuff. I mean,
Right.
but that's one thing that got me thinking about El Paso as a unique allergen environment.
So here's a question that's kind of our day and time with people wearing masks. Yes, the masks were because of COVID. But do you see the mask being beneficial in the future? Let's just pretend magic person waves a wand and COVID's gone. Would there be certain times of the year that wearing a mask for people who have severe allergies would be good? Or is it, and the reason I say that, that's just respiratory. We're not talking about skin allergies and food allergies, et cetera. This is just, I guess, more than anything, pollen allergies, which spring and fall seem to be the big ones.
So the question then becomes, will masks
Are they here to
Will
stay?
they help? Will they help
Yeah.
us like forget about allergies?
Yeah, filter it
No,
out, so to speak.
No.
Okay.
And the reason
Okay.
is that we don't. I mean, we'd have to wear some masks that would be very hard to breathe through because of the size of pollen and mold particles, and these are very small things that can probably penetrate most masks. Whereas, you know, viral particles travel on fomites or pieces of saliva and all that.
Right.
And you know, that's how they get to you. But having said that, does it help? It probably does help to some degree, but it depends on the type of allergen
Makes sense.
that
Yeah.
you're allergic to. You know, so like some mold spores are so small, I mean, no mask is going to stop that.
Right.
And if that's what you're in contact with, I don't, you know, you'd have to wear a spacesuit,
Right,
basically. You know,
exactly.
it'd be beyond a mask. But I'm not saying masks are useless. I'm just saying that they may help. But particle sizes make a big difference.
Yeah.
And that's really what mask science is all about.
Okay, and you still have the eyes exposed too, which is a big thing. Dr. Escobedo, I'm going to ask you this because it's going to counteract something else I'm going to ask Dr. Casillas. When somebody comes into your clinic and they are tested negative, let's say 100% they're not COVID positive, they're not flu positive, so it's a cold or allergies, etc. And this is where it gets loaded. There is, you go to any drugstore, you go to your Walmart, wherever you go, and there's decongestants, there's fever reducers, even though there's not a fever. In general, you're looking at a world of medication over the counter. What is it that either your patients have asked you or advice that you give them when they are feeling all icky and mucusy, but you know they're negative, you know it's gonna go away, or that it's not something that they're in danger of? What do you tell them, and what do they ask you? Because you can't help it. There's an entire aisle of stuff to look for, and I know sometimes I go there and I'm like, I have no idea. There's a decongestant and there's something that's
Well, it depends on the symptom, right?
Right.
I always ask them, what is your main symptom? What is the symptom that's bothering you the most? If it's nasal congestion, well, you know, there's some decongestants that can help, and like over-the-counter medication usually has like an allergy medication on it, right? And a decongestant. So you can take that, but if you have other conditions like high blood pressure or diabetes or anything like that, you might want to ask your doctor first if you can take certain type of decongestants, right? Because that can elevate your blood pressure, etc.
exactly.
But most of the other of the over-the-counter medication works pretty well. The other thing that the patients love to ask for is the allergy shot. And I'm like, well,
that's my next question to you, so get prepared for that one.
Yeah, so when they ask for that, I'm like, well, you know, there's not an allergy shot.
Like
you
one,
know.
like one allergy
Yes,
shot, right,
if
exactly.
you want to get tested for allergies and really know what you're allergic to, then you should probably see an allergist, right? But what they're referring to is the steroid shot, because I get it every year, etc. You know, so I'm not for that. Like, it's not like a treatment, right? I mean,
exactly.
if they're severe and all of that, well, maybe we can consider it, but it's not like first line.
Yeah, that's not something you want to
treatment.
just put in your system just to put in your system. So that was a perfect way of introducing. And I know it's loaded, I get it. What are you allergic to? You, meaning the person on, you know, they are watching right now. What are they allergic to? And once that is found out, the series of injections that people may choose to have, or do they just choose to take a decongestant the rest of their life, etc. I know it's loaded, and it takes 4 or 5 shows to do that. But let's first go through the process of people that are they're just allergic people. They're allergic to everything. They come to you and they say, okay, what am I really allergic to, and what can I do in the future to just help me more comfortable going forward?
So that's an excellent question, because it is at the crux of, you know, what I do. You know, at what point do you start recommending you need to be desensitized? So for some people, it's as simple as I get symptoms in the spring and the fall for a couple of weeks. I take some antihistamine that's over the counter, maybe a nose spray for a few weeks, and I'm okay. Fine. You treated your symptoms, and that's what was bothering you. You can continue.
Their quality of life is still okay.
And that's what's
Right.
important to think about. I mean, most allergy patients, they just want to hit that 100% mark. They want to be at their full capacity. And that may be enough to do it. And if I tell them, that's fine. If that's all it takes and you're comfortable with that, fine. But then there's the patient that I'm miserable all year round. I don't get a break, okay?
Right.
Because every season there's something in that season that I'm allergic to, and I'm the one. And I see those patients all the time. Or I'm allergic to, what we call a perennial allergen, house dust mites, right? For
Right.
example, they're always there.
My
right?
son's that guy. He's allergic to everything. Kills me.
Okay, well,
Poor kid.
and they're miserable. They never
Yeah,
get a
they're
break.
constantly, I call him Mucus Boy. Totally not kidding. He's just got it going on all the time.
They never get a break.
Yeah.
They never get a break. So
Yeah.
this is the kind of patient that I think now you recommend true allergy shots. Now, allergy shots in my world means the kind of shots that desensitize you. They actually change your immune system. And what that means is that right now, the reason you make allergies at a molecular level is that you make a certain type of antibody. It's called IgE, like elephant. And if you didn't make that, you wouldn't mount an allergic response.
Interesting. Okay.
You can change that to some degree, and that's what allergy shots, and then there's other types of allergy therapies that you may have heard of, but we're talking about allergy shots, and it's a way of telling the immune system, we're going to do things a little differently, okay? And it's a concept of it's simply introducing the allergen through a different route.
I see. Okay.
It's kind of that simple. But what happens now is that the immune system will change, it'll modulate. And over time, this is a process, this isn't like a quick fix. It's a process, and it takes effectively a few years to happen. I explain to patients, it's like putting on braces. Your teeth are not going to be straight day one.
Right.
It's a process, but it's possible to do. And for the patients that are very miserable, they really suffer every day of their life,
Yeah.
just about.
Yeah.
They're going through medicines like crazy. The medicines
And there's
don't
that
work.
worry too, right? And
Sure.
You're thinking about all these and you had such an excellent point. There are some medications that raise your blood pressure. There's hypertension, there's all kinds of issues if you're just constantly taking medications. And I think that's where the relief is being sought.
Right.
Is there something where I'm not constantly taking the little red pill? Like my kid, I feel like we buy these little red pills by bulk, and that's the big question. And how, I guess it depends on the person, how long does it take for the series of shots to be over? Like a year, like every week for a year? Looking at different things that you're allergic to, how does that process? And I know it's different for everyone, but in general.
So in general, and I'm talking about environmental allergens, it's a process that usually requires weekly shots for a period of time to reach a maintenance dose. Once the maintenance dose has been reached, then a monthly shot can be pursued at that point. And that will be enough to stimulate the immune system
Okay.
to the point that then you can build that repertoire of B cells. Those are the cells that make the antibodies, so that it's large enough that it'll last the rest of your life potentially.
Interesting.
So,
okay.
so you don't have to do weekly shots for, years and
Yeah.
years. You shouldn't, in fact. If you're doing it, it means something's not working.
Right, exactly.
And, that's when I urge you to come see me. I'll fix that because
Yeah.
that's not right. So bottom line is that you do have to do weekly shots for safety. We start at a small dose and work up to a high dose, and that's for safety, Otherwise,
Makes sense, yeah.
We're injecting people with stuff they're allergic to.
Exactly.
And then once you reach that maintenance dose successfully, it means your immune system has already made some changes. Now we want to amplify that effect. And so to do that, we then go to a monthly injection for another couple of years. The best data is anywhere between 3 and 5 years.
Okay.
Okay?
And so would you say, and I don't know if you have this number in your head or even a guesstimate would be fine, percentage of population, and let's take El Paso because you are here now, percentage of population that have severe allergies that have to do with our weather, that are external allergies, not peanut allergies or food allergies. Would you say in El Paso it's 5% that are, and I say severe enough to where somebody is seeking help with injections for the rest of their life, Or I'm very lucky, knock on wood, allergies don't really affect me, and I've been very lucky that way. Here's the other question, why does my poor kid, and granted he's got a mother and a father, I get it, there's genes from two of us, why is that poor kid cursed with just constantly being in, misery, and other people, it doesn't bother them at all? I mean, I can walk into a windstorm, go home, and I have no issues whatsoever. Why?
Okay, well, let me start with the more facetious type of
Okay.
answer. There are some people you can cut their arm off and they don't complain, okay? All right? So it's also a matter of perception, okay?
Yeah, that's a
All
good
right?
point.
So,
That's a good
some
point,
people
right.
they can sit there and drip mucus all day and they don't care, okay?
It's like, I don't
They
have
don't care.
cancer, I'm good.
So I'm all right. Just
Right,
leave it, right?
right.
So that's
I get it.
part of it.
Yeah.
How much does it bother you? Okay?
Yeah.
How much does it bother your mother? Well, okay, then do it for her.
Right.
So anyway, the percentage of the population, in general that have pretty severe allergies, I mean, it's more than 5%.
Is it?
Way more than
Okay,
5%.
okay.
Yeah, I mean, in general, it's probably going to be closer to the 30% that have some allergies that are of significance to them that they will seek professional help for that. That's
Okay.
a high number.
That is a
That's
high number. That
That's
is a high number. Yeah, higher than I expected.
So, but then it's a matter of the threshold. At what point have I had it? I can't do this anymore.
Mm-hmm.
And there are some people who say, oh, "Come on, dude, it's just your pinky. It's all right." It's like. But on the other hand, it's like, well, wait a minute, it's my fingernail.
Right.
I'm not going to let you. It's
Right.
a matter of how much does
That's
it
an
bother the
excellent
person.
point. It's a matter of perception. Yeah.
Because most people don't die from their allergies.
Right.
Now
They're just
that excludes
uncomfortable.
drug, food, and other dangerous
Right.
type of allergies. But most pollen allergies and aeroallergen allergies are not going to kill you. Although if you have asthma, it could.
Mm-hmm.
So I'm not saying that as a blanket statement. Okay, but so there's a matter of perception, and Dr. Escobar sees it all the time too.
Mm-hmm.
I'm sure there's patients that you see that you go, well, wait a minute, this is not that bad. You could take a antihistamine
Right.
for a few
Yes,
days.
but
and
they
Right.
say it's severe.
yeah.
They
Right.
do.
And those are the
Actually-
patients that want the allergy shot, the
Yes,
steroid.
exactly. Give me the
Now.
steroid. And you had a good point too, and Dr. Escobedo, because you talked about the steroid shot earlier, and I do want to bring up asthma, because when you do have asthma and this part of the year, it does kick things up. There's also because you're a family doc and you see all the ages, you said earlier, which I think is really nice for this question. There are kids, when I say kids, there's a development, it seems to me, or we've had programs on this before, that asthma is kind of developed as a child, but then after age 16, 17, 18, it seems to kind of go away
Actually, it's
for a
9
couple
years
of decades.
old.
Okay, so just talk about that phenomenon.
I honestly don't know, but
Okay.
that's what is documented. After 9 years old, it's if you had like childhood asthma and all of that. 9 years old seems to be like
The magic age, it just goes away? So you trade, asthma goes away, and then you get all those ugly hormones that make you crazy for a couple of years.
I guess so.
And then after that it comes back. I've always been fascinated
Some
with that.
people don't ever get it back.
Okay.
They just get over with and that's it.
So as a family physician, and we're talking about, again, is it a flu, is it a cold, is it COVID? I'm having a hard time breathing, which in the early days of COVID, that seems to be the one symptom that people are like, okay, the breathing is very, very difficult. Let's marry that question now with those that have asthma, maybe are being treated for asthma. Now maybe COVID enters the picture. However you want to answer that question and marry all of that together, let me know what your thoughts are on that.
There's a broad differential diagnosis for anyone that comes in with respiratory, right? It could be
Okay.
acute bronchitis, it could be chronic bronchitis, it could be asthma, it could be exercise-induced asthma, COVID, flu, pneumonia, right? So you kind of have to pick and see the syndromes, right? Oh, this looks more like COVID. Let's test for COVID and flu, right? Because COVID and flu kind of
They
all
look
the
similar,
symptoms are
yeah.
very similar. Now with the Omicron and the different variants and how we've been vaccinated, you're not seeing that much of the respiratory with those two, flu and COVID, right? But if you're not vaccinated, obviously you have to get it in your head that it might still be that.
Right.
So now we come into March, April, now it's allergy season, so it comes more to the front of your head, the allergy and the asthma and all of that stuff is causing your asthma now. So it kind of depends on the whole picture.
Okay. And when you're looking at asthma, again, as a family doctor, goes away around nine-ish years old. The children that come in that do have asthma, bronchitis, et cetera, and they are positively diagnosed now, and let's say the symptoms are not severe, but they are positive for COVID, we already know that they have bronchitis, we know that they have asthma. What are the treatment options there? Are the treatments different? Are they just looked at with a little more caution? How does that whole scenario work out?
If we're talking about children, well, there's not really anything that we can use for COVID, right? If you're a little bit older, and there's emergency treatments for that, right?
So there are no therapeutics per se for children, and so when I say
for COVID,
children,
but
for
asthma,
COVID, right.
asthma would be treated the
Right.
same, right?
Okay, so asthma, okay, so if it's exacerbated by COVID, you're still treating the asthma in and of itself, even though there's COVID, and there's not really a therapeutic for COVID.
Yeah.
Until, and you know what, that's a good question. Until what age are therapeutics introduced into the scene with COVID treatment? I'm just throwing out to anybody who wants to answer that.
Well, you probably see.
I see
broader
more.
age.
Okay, go for it. So is that
So,
16, or is it,
Well, they've done 18.
they've done 18 above? Okay,
Yeah.
okay.
But
And when
as
we
we
say
progress,
therapeutics, for the audience, sorry, I should have said that, but therapeutics is a specific treatment, so actually treating COVID.
there's different types of treatments now, right? There's
know,
the
there's so
autoimmune
many.
treatment, the antivirals. So the antivirals are kind of like where we're going to be at maybe next year. Everyone's going to get an antiviral, kind of like flu, right?
Okay.
You get an antiviral like Tamiflu. Sorry,
So if
I
you're
can't use
diagnosed
it.
with COVID and showing some symptoms, chances are, starting next year or so, at least what we know of, people are probably going to get an antiviral.
And I would say
therapeutic.
that that's probably going to be a very cost-effective alternative.
Okay.
I mean, we saw with COVID that, you know, we were rushing to do, well, first, strange things. that,
Right.
you
Well,
know,
we were
that-
scared
Yes.
to death.
Yeah,
Yeah,
of course.
of course, yeah.
Then secondly, you know, we had monoclonal antibodies. Very expensive, but hey, they did work. They did work, there's no doubt. But very expensive. And now that there's a line of antivirals, and certainly, you know, as COVID becomes endemic and cases become more or less serious, the choice of using those kinds of agents will be something that I think will be more commonplace.
And we also know that if you have asthma or chronic bronchitis, any type of viral infection or bacterial infection can exacerbate those two conditions. So,
Right.
you know, we need to be more careful about those particular patients.
Exactly. It's funny because there's, not funny, but there's a caller specifically that just typed in a question right now wondering what the relationship is between allergies and asthma. And I don't think technically that there's a relationship
No,
between.
there is.
There
There's a
is.
strong relationship.
Dr.
There's a very
Casillas, let's
strong
take that one.
relationship.
So what is the relationship between the two?
You know, basically, most asthmatics do have some allergic sensitization, and that is going to drive some of the inflammatory response.
Okay.
Certainly not all of them. There's different kinds of asthma, if you will, but a large number do have allergies. And in fact, in the treatment guidelines now, doing allergy therapy is really a strong point. Okay? And you can actually reverse this in some people. And then some of the biologic agents, and by that I mean all those weird TV commercials that you see, you know, tell your doctor that
Right,
you may get
right.
tuberculosis.
Oh,
There you go.
I can't
You
say that,
say
right?
But anyway, that's okay. So the bottom line is that those actually target allergic pathways, okay?
Okay.
All of those drugs that are specific for asthma as biologic agents.
Okay, that
Right
makes
now, and we have, right now, you know, there's actually 4 common ones, and a few others are kind of working their way in. We're going to hear about a number, you know, it's the way.
And just throw in the word inhaler, because I just feel like asthma, inhaler, it just
Okay.
goes hand in hand.
I will.
Okay.
Yeah, so anyway, so those are allergic mechanisms
Okay.
that are addressed by those. Now, asthma inhalers, they're just a mechanism of getting particles into the lung. That's what an inhaler does.
Okay.
And the reason they're effective in asthma is that if they can reach those parts of the lung that are having bronchospasm, and the particular drug is a bronchodilator, that would be things like albuterol and other long-acting
Right,
bronchodilators. That is effective. And you can also deliver anti-inflammatory medicine through that mechanism as well. Inhaler
And is
just
the
makes
idea
it,
that it's quick, it's immediate, or?
albuterol, in the case of albuterol, it's pretty quick, yeah.
Okay.
And other medicines are pretty quick as well. But having said that, there are some medicines that are really designed for chronic use, and they're not really quick. They're just designed to be used every day to control you. And then there's albuterol, which is what we call a rescue medicine. That works pretty
I am
fast.
so familiar. Again, I'm a mom of a boy
Yeah.
that's, albuterol was our life for many years.
Yeah.
And interesting on that. I have a question also here from the audience, because we were talking about flu shots, we were talking about COVID, we were talking about allergy shots. And here's that question that was raised a lot during the fall when flu shots were being promoted heavily and COVID shots are also being promoted heavily. We are now, I think you said we're at about a 60% rate of full vaccinations, more or less, in El Paso. When vaccines are introduced, is it okay to get a COVID vaccine, a flu vaccine, and then maybe throw in some allergy shots in there, not steroids, but and however we want to talk about that conversation, because it's all about, okay, let's get the antibodies going. What is the conversation now in the medical field with that? And I'm throwing that to either one of you who wants to take it.
Well, I can answer the COVID and flu.
Okay, gotcha.
Because you can definitely get those together.
Okay.
But if you have maybe, you don't feel as good or you're frail, and you think that you might get side effects from that, right? Being you're fatigued, you can be in bed for 2 or 3 days and there's nobody to take care of you.
Right, yeah.
Because we do sometimes feel more fever or fatigue or muscle aches if we get them together. I sometimes recommend patients spacing it out, maybe 2 weeks or a month if they're in that situation. But they can definitely get it together if they're, let's say, 50 or below,
right,
and they're in good health. Right?
And I do want to say this too, because it's a question that's asked of me a lot because of this program and just things that we do. When people receive the COVID vaccine and the flu vaccine, it is, for the most part, normal for them to have side effects, because you will hear the old wives' tale out there. It's like, oh, well, I got the flu shot and it gave me the flu. It will most likely give you a side effect, which is good because it says that your body, in fact, that's a good question for you. Why is it good that your body reacts to a vaccination? Because you spotted that earlier.
So when you get an infection, by a virus or bacteria or whatever, your body responds with inflammation. That's what you feel. So, fever, redness, all of those things are parts of a structure of inflammation. That's what you appreciate.
Right.
Okay?
Right.
That's what you appreciate. If it's real severe inflammation, that's also what kills you, right? So one has to understand that it's normal if I give you a part of a flu and your immune system says, oh my God, it thinks it's the real flu, guess what? It's going to also mount an inflammatory response.
Exactly.
You're going to feel it, okay?
Right.
You're going to feel the soreness. You might even get a fever. All of those things might happen. But you can't get the infection from a piece of a virus.
Right.
That's what you have to understand, that you can't get an infection from an incomplete viral particle, and that's
Say that 3 or 4 times, because I really want people to understand that.
If you need part A, B, and C to mount an effective infection, and I just give you part A, and that's enough to protect you, it's going to protect you. It's still going to mount inflammation. You're still going to feel it, but guess what? You're not going to have an infection. Okay? There's different ways of achieving that. Our traditional approach has been just give that piece of protein, and that's what traditional vaccines have been. But now, there's new types of vaccines, and with the COVID, we were introduced to the mRNA vaccine. Well, that technology is not new. It's been, it's been explored for many, many years. And it's just, who makes that protein? Do we make it in a lab and give it to the person? That's one way. Or do we give the instructions on how to make that protein to the person and let their own body do it? That's what the COVID vaccine did.
That's a beautiful way of saying that. Do we give the instructions to your body and let your body create the antibodies? That's the best way I've had that explained so far.
Yeah.
Thank you for that. We are at about a 9-minute point of the show ending. It goes fast.
Oh, I
so
wanted
what
Dr. Casillas to explain to the audience if they can get the flu, the
allergy shots
allergy
along with the
shots
COVID.
with
Sure, it's a great question.
Yeah.
Theoretically, yes, you can do everything you want at the same time. We do that to kids all the time, right?
We do.
Let's give you 5 vaccines today.
And they're 2 months old. It's like, here's your 6 shots.
Yeah.
Yeah.
We do it all the time. Why? Your immune system's pretty smart. It's hard
Right.
to break it, and it's going to adapt correctly. If that wasn't possible, we would have never made it evolutionarily, because we were exposed to hundreds of thousands of things probably, throughout our history that, we had to deal with at the same time.
Right.
So our immune system's kind of used to that. So theoretically, yes. It's when you have a bad reaction, and it's real bad, it throws you on the floor.
Right.
Or it does worse to you. Ooh, which one was it?
Exactly.
Was it the chicken or the egg?
Right.
It was, we don't know now, we don't know. So that's why it's kind of, if you have the luxury of spacing it out, then that's probably the smart thing to do.
Yeah,
Just
yeah.
if you have a reaction, then at least you know, okay, you know what? And there are certain patients, it's very rare, but there are patients that I have recommended do not get this vaccine. It's probably going to pose more risk to you than benefit.
Okay.
And when you realize that, it's because, yeah, I had the first vaccine and, oh my God, this and this happened. I said, oh my God, that's awful.
Yeah.
You know, sometimes you can deal with it, and other times it's just too risky. It's like, what do you mean?
And the hard thing is you just don't know. I mean, that's, again, when we come to that.
And if you give 5 things at once, guess what? You don't know which one.
You don't know which one is the one. I respect it, and that's, again, that's with our audience, again, we've got the questions, and it is a science, which means it's always evolving and revolutioning every day. And with us nearing the end of the show, as a family medicine doc, is there something today that we have not talked about that you'd like to get across to patients, or some questions that you're asked of often that you can address while we're here? And I'm going to ask the exact same question of you. Yes, we're in this topic of mucus all day, every day, but just in general too.
Yeah, well, I just want patients in general to understand that you can get COVID more than once in a very short period of time, because what we were talking about, the variants, right? So you can get COVID. It
doesn't make you immune.
It doesn't make you immune forever either, right? It might make you immune to that particular COVID variant, but it won't make you immune to all of them. Right?
So there's not a reason to let your guard up just yet. Is that what you're trying to put out there? Nicely said. Dr. Casillas, anything that we haven't covered that you'd like to? We still have a couple of minutes, but I always like to allow a little extra time for this.
Yep. I mean, I encourage people to get their full vaccination because vaccines are a way to get, you know, to eliminate disease, or certainly to bring the severity of it down. And I think that's an important thing. You know, we already live in a complex enough world where we're exposed to things that we weren't exposed to, you know, toxins of certain sorts, you know, even, you know, radioactive sources. There's just a lot of things that hit us all the time, you know.
Right.
Even the food we eat, you know, it's got plastic in it now, right?
Oh, yuck.
You know,
yes.
so we're taking a lot of hits, and so maximize your immunity at least. You know, that's something that you can really rely on, and I think it really will help. You know, for the most part. Yes, there are certain cases you're going to hear about where people have adverse reactions. People have adverse reactions to many things.
Right.
You can cross the street and have an adverse reaction. And so there's nothing that's 100% safe. And I think that, you know, but we have to weigh it in terms of, you know, what's the potential risk.
So I have the burning question I had that kind of belongs in tonight's topic and kind of not. It's something I'd asked you about before the show. And it's kind of like being 9 years old and all of a sudden your asthma is gone. But talk about people who have not had allergies all their life, and we joked about this part of the show, right? And all of a sudden they're 30, 40, 50, 60 years old, and now something that has never bothered them before, the exact same substance, whatever that is, now they're allergic to it. How does our body do that? Physiologically, what's happening? You were saying earlier that for us to be allergic to something, our body needs to be introduced to it. Correct. Could it be that our body has just been introduced to it so long and now it's fed up? Or what is the explanation of all of a sudden you're allergic to something you weren't before?
So it's not an easy question to answer directly, but...
That's why I waited to the very end.
That's okay. First of all, you have to be genetically susceptible.
Okay.
All right? You know, if you can pick one parent, do it. If you can pick 2, do that. You know, or if you can pick your grandparents, that's even better.
It might be scary. 20 years from now, people can do that.
So genetics is going to play a role.
Right.
Can you mount an allergic response to begin with? Number 2, is there sufficient exposure to stimulate an allergic response in the immune system? And how many exposures does that take? God only knows.
Right.
We don't really know, and it's different for different people, okay? So given those factors, you know, can you mount a response? Is there sufficient exposure and length of that exposure? Those are the factors that are going to go into saying whether or not you are going to be a person that actually suffers from that. But you see it all the time, especially with medications. Like, well, you know, I got this medication a few times, and it's not till like the 15th dose that, oh my God, now you're allergic to it forever. And
right.
So it's not a question that it can be answered specifically, but it does require a period of time, a genetic susceptibility. And then, and then sometimes there's comorbid factors that may go into that process as well.
That makes sense. And the question too, and I know we were talking about a vaccine program, that you have vaccine number 1, vaccine number 2, and then the booster. It's my understanding that all 3 are the exact same vaccine, exact same amount of vaccine, but the body may have reacted to it differently the times that it got it. And the reason I'm asking this is that because of the perfect storm. I think what you're talking about, it's the timing, it's what's being put in your body, it's how your DNA is going to react to it anyway. Is that kind of the same answer of why some people may have not reacted to the first vaccine, but then the second vaccine, which was the same as the first, they did react to that one? Again, easy for me to ask.
It's a matter of probabilities. There's a probability that after the first vaccine, you're going to be protected. But if you look at population statistics, you're going to say, well, that's only 60% of the population, though. So we want to try to hit 90%.
Right.
So by giving vaccine number 2, we can approach that. Even though that first 60% is already there, it's not going to hurt them to do the second part.
Right.
And that's really what this is about. This is about, we could do it. Oh, well, we'll study everyone. It's going to cost too much to do that.
Right.
So we do it. With hepatitis vaccines, it's 3 vaccines, right?
Right.
And there's different vaccines that require different doses for that reason. Some people will get the protection right away, but
people
not
may never get it.
And some
And
people
some
may
people
never
don't.
get
That's a
it.
good
That's
point.
right. Some
I'm
people.
one of those.
It's a very good. Oh no.
So tell me why you're one of those. I know, it's just the way it is?
Just the way it is.
Just the way it is.
Well, I have other things going on, right?
Right. Okay.
but-
I'm being too personal now.
Yes.
So here's a
I'll tell you
question from the audience and from everyone, and it's a pie in the sky answer question. When do you all, just in your best medical educated guess, would we be looking at yet another vaccine for COVID? I know we're looking at variants. We think things are kind of slowing down. We've got a whole minute. And again, it's a guess, and I get it. No one's going to hold you to it. But just in the back of your heads, you think in the fall we'll probably have to get another
There's
booster?
already an indication for people that are immune deficient.
Okay.
So you can get the 4th vaccine if you've already gone 4 months from your booster.
Okay. And so that's usually about the time frame, 4 or 5, 6 months.
4 to 6.
Okay.
Time will tell, but I think it's probably, as this thing becomes more endemic, it's going to be something that at least will be yearly.
Right.
Maybe even incorporated with other yearly vaccines.
With the flu.
With the flu, and that was going to be my next question, but we're running out of time. I think you guys, this has been a great show, and I know I thought to myself, okay, we're going to talk about COVID again, but this has been very enlightening, especially introducing allergies in this time of the year, so I appreciate very much you all being here. I want to say thank you to the American Heart Association for underwriting this show, and also the El Paso County Medical Society. I'm Catherine Berg, and you've been watching the El Paso Physician.